We're back with Sheri, a member of our doctor's family who recently found out she had cancer after she had a mastectomy. She's now in the difficult position of deciding whether or not she's going to undergo chemotherapy. So I want to bring in Dr. Banu Arun, oncologist and professor at the Department of Breast Medical Oncology at the MD Anderson Cancer Center. So Dr. Arun, her pathology report said that she had triple-negative breast cancer cells, and she's also BRCA1 positive. First of all, explain those two situations, and then explain what the recommendation may look like for someone in her situation.
Yes. So triple-negative breast cancer means that the tumor cells are negative for the estrogen receptor, negative for the progesterone receptor, as well as negative for the HER2 receptor. These are the three main receptors we check that help us guide treatment.
So you have her path results, and I know you're not Sheri's doctor, but in these kind of situations, what kind of recommendations or what kind of modeling or decision tree would you go through to make a recommendation?
The most important factors include the tumor size, the lymph nodes, and then these receptors, as I mentioned, triple-negative breast cancer. So when a decision to calculate the benefit from chemotherapy is made, we factor in all of these clinical features to come up with the best decision that would help our patients.
And Dr. Arun, it's my understanding that in the case like Sheri's, where we have a BRCA1 and we have a triple negative markers, that this does respond well to chemotherapy.
That is correct. Preclinical and importantly, clinical prospective large trials have shown that triple-negative breast cancer is actually chemotherapy sensitive, and that adjuvant therapy, so chemotherapy after surgery, can reduce the risk of this disease coming back anywhere in the body between 30 to 40%.
So Sheri, when you hear this, what goes through your mind as far as you're considering what type of treatment that you may opt for?
Well, it's still confusing because my pathology report also said that I had lymphovascular invasion was not evident. Right now, I don't know if any cells are traveling through my body, and there's no specific tumor to treat. So I would just literally be putting my whole body through a toxic regimen just in case. And when I went to one oncologist who put all my stats into an algorithm, it said that I had a 6% benefit from chemotherapy after surgery. So the surgery was the main benefit, and then if I decided to do chemo, it was only a 6% benefit.
Dr. Arun, she's sitting here and she looks at these numbers, 6% maybe chance by having chemo. Should she do it or should she not do it?
That's why the discussion is difficult, because you are trying to decide whether you should take chemotherapy to prevent something that might never happen. For some patients, anything above 2% is good enough to receive chemotherapy. For some patients, it is not.
Part of me is a researcher, and I like to get all of the facts, and I'm probably looking at too much, but I'm also reading articles about how cancer can metastasize in other parts of the body because chemotherapy has made those sites a better host. And also the side effects of chemo, having a port put in, the short-term side effects, possible cardiotoxicity or neuropathy, all those things come into play, and it's a big decision.
Sheri, there's a lot to think about for sure. We're not trying to put you on the spot, but you know, the idea is, like you say, do your research, and you always got to figure out what's best for you, because what's works for someone doesn't work for everybody else. So
Exactly.
we wish you the best, and let us know what you decide. But be healthy. We're happy that you caught it early. And Dr. Arun, thank you so much. It's not easy to advise. Every situation, every case is different. So we really appreciate you weighing in today.
Thank you. Thanks for having me. Good luck, Sheri. Thank you.
Thank you. Thank you.
All right, guys.